Good morning, good afternoon, good evening, and welcome to the fourth in a series of webinars on the practical education of bleeding disorders, Knowledge for All. This is Tuesday, December 16th. We will spend the next 2 hours going through a number of different presentations, which will allow us to cover a number of different aspects of bleeding disorders care and treatment. My name is Glenn Pierce. I am the Vice President of Medical for the WFH, and it's my pleasure to welcome you as well as all of our speakers to this session. The session is divided into 2 different hours. In the first hour, I'm going to start by providing an update from the ASH Congress. We'll get into some dental issues, liver health, and have some time for questions and answers. And then in the second hour, we will cover obesity, a rising epidemic in the hemophilia community and the bleeding disorders community in general, as well as pain and mental health, finish with some questions and answers and closing remarks. It's my pleasure to welcome our speakers who are listed here. I'd like to begin to introduce the first hour speakers, and then Cedric will introduce the second hour speakers. So in the first hour, Lochana Nanayakarar is the current chair of our WFH Dental Committee, and she also works as a consultant in restorative dentistry at Barts Health NHS Trust in London. Bruce Luxon will be speaking on liver health, and he is the chair of the Department of Medicine at Georgetown University Medical Center and the chief of service for the Department of Medicine at Georgetown University Hospital in Washington, D.C. And then I will leave it to Cedric. I will introduce Cedric, but then Cedric will introduce his the remaining guests for the second hour. Cedric is a WFH board member. He is the editor-in-chief for the Hemophilia Journal and currently heads the Division of Hematology in the Hemostasis and Thrombosis Unit, as well as the Hemophilia Center at the St. Luc University Hospital in Brussels, Belgium. So with that, why don't we get started? So I'm going to give a few remarks on the ASH meeting, which just ended a couple of days ago. I can't possibly cover everything that was covered in hemophilia at this meeting, but I've picked 5 or 6 talks that I'd like to give you just a brief summary on. The first 2 that I'm going to cover are on fitusiran. This was the subject of a plenary as well as a late-breaking abstract, so a lot of attention for fitusiran at this ASH meeting. Fitusiran, to remind you, is a small inhibitory RNA that interferes with antithrombin. Antithrombin is important in stopping coagulation before it runs out of control. So it's an important molecule that will shut down coagulation and shut down the thrombin burst. Fitusiran comes in and inhibits antithrombin, allowing coagulation to proceed for a longer period of time. In this talk from Guy Young, you can see that the balance between procoagulant activity and anticoagulant activity, or coagulation inhibitors, is tipped when we have factor 8 or factor 9 deficiency in favor of the inhibitors, and we have a bleeding disorder. Fitusiran then can potentially restore that balance so that even though a patient doesn't have factor 8 or factor 9, if a lot of the antithrombin is shut down, that will allow more coagulation to occur, less inhibition to occur. That's the principle behind it. And so the subject of these 2 talks, which are called the ATLAS studies, involved the use of fitusiran on a monthly basis and then looking for safety and efficacy. Fitusiran was dosed 80 milligrams subcutaneously once a month. and the diagram for the trial is shown here. I would point out that the comparator arm is not a prophylactic arm, but is an on-demand arm, and this was an inhibitor trial in these patients. And what you can see is what was shown in the phase 1/2 study. There's a large decrease in the annualized bleeding rate from a relatively high value with hemophilia A or hemophilia B down to a very low value. These are medians here that are shown for both hemophilia A and B. So no unexpected surprises there. The safety and tolerability is shown here. There were some increases in transaminases in 12% of the patients. And then there are 4 instances of thrombosis, 3 of which occurred in the same subject in different places and had been reported as adverse events in the past and actually resulted in a hold on the trial earlier this year. The second talk was from Aloxarivastava, and that was on normal individuals with hemophilia without inhibitors, also called the ATLAS trial. And very similar results were shown. We can see here that we go from a relatively high bleeding rate in the on-demand treated patients down to a low bleeding rate. This is for all treated bleeds. This is for joint bleeds. And so similar again to what we saw in the phase 1/2 trial, fitusiran is effective in really eliminating the vast majority of bleeding in patients. The safety slide here does continue to show some transaminase elevations in 15% of the patients. No evidence of thrombosis in this particular set of patients. So I also think it's important to have some fair balance here because these 2 talks really minimize the thrombosis events that did occur with fitusiran over the course of the last six years or so. And so they both had a summary that was very similar that really didn't address the thrombotic risk. But I do think that it's worth pointing out that there have been a total of 5 thrombotic events in the program. This trial has now been restarted at a 70% dose reduction. So from 80 milligrams a month, which is what both of these 2 trials I just showed used, down to 50 milligrams every other month. And so patients are now being recruited at this substantially reduced level, which will reduce the inhibition on the antithrombin. We don't know what that will do to the bleeding rate in the patients, and that's the subject of investigation along with the safety to see if it can eliminate the risk of thrombosis. Would also point out that in contrast to more recent trials, this trial compared patients on fitusiran to those who are on demand and not those who are on other prophylactic regimens as the gene therapy and the immiscismab trials have done in recent years. So that's another difference to highlight that wasn't necessarily highlighted in the talks. I want to move on to another talk, this one from Claude Negrer, who talked about immiscismab prophylaxis, this time in persons with mild or moderate hemophilia. So this was a nice talk that really covered in detail how individuals who don't have severe hemophilia A can benefit from immiscismab. And as one might expect, they did respond. They did not have much in the way of adverse events and did quite well receiving immiscismab to decrease the smaller amount of bleeding that they've got relative to the severe patients. And then a second talk I wanted to highlight comes from Giancarlo Castaman, who looked at surgical experience. And surgery has been used, was identified and used in the clinical trials for immiscismab. There have been a number of papers that have looked at small series. This was a larger paper that really looked at it in detail and provided a step-by-step guide for doing surgery in individuals on immiscismab, both with and without clotting factor replacement. And as one might expect, minor surgeries responded well to immiscismab, generally not requiring clotting factor replacement. Major surgeries did require clotting factor replacement. The suggestion was made that prospective design in managing these patients during a major surgery is really required to think through the amount of clotting factor required, the length of time the clotting factor is required as well. I also want to look at surgery in patients receiving concizumab. Concizumab is an anti-TFPI, tissue factor pathway inhibitor. And as you all may well remember, TFPI works with factor VII to form a complex that then will activate factor 10 to 10A. So it's an alternative way of activating 10A and getting the thrombin burst. And TFPI is an important control in that system to shut down that initiation. Anti-TFPI, which is an antibody, will prevent TFPI from doing that and allow initiation to continue. And so this has been the subject of a number of different clinical trials, and suffice to say that they described a number of different surgeries and various minor surgeries or procedures using anti-TFPI successfully to get sufficient thrombin generation to prevent bleeds. They did require clotting factor supplementation for any of the major surgeries, just as we saw for immiscismab. So some good data there. I gave a talk on financial stewardship in an era of hematologic advances in care, and so it was a different kind of a talk. And I worked with a group of people that looked at a whole spectrum of hematologic diseases. I went through the progression of costs for the hemophilia population, beginning with cryoprecipitate, which costs perhaps $3,200 a year for patients back in the 1960s, up to and including the use of extended half-life recombinant factors, bispecific antibodies, which in the US are running $500,000 to $600,000 a year, and covered a number of the advances and the increases in costs as a part of value-based medicine. I did go into some detail about the disparity and the inability to deal with those costs in most of the world, and provided a little bit of information on that you're all familiar with based on our annual global survey work. And then I also covered gene therapy and the costs of gene therapy. And I took some public information from an article Pfizer had written. And I just point out maybe one example here. We have an approved product for a retinal disease, a congenital retinal disease, that is selling in the US for about $400,000 an eye. And the cost to make that is about $500 a dose. And so the costs of gene therapy are not that high relative to the charges for gene therapy. And I go on and talk about liver and muscle as well, with also high differentials between cost and charge. And then I want to move on to the genotype-phenotype relationship, looking at inherited factor VII deficiency from Susan Halama. And she did a nice job looking at a lot of different individuals, correlating genotype with phenotype, looking for reasons why two individuals with the same factor VII level can have very different phenotypes. One may bleed a lot, one may bleed very little. And she didn't find a lot of correlation in these 1,200 individuals. She found some low correlations between blood group O versus non-O, presence or absence, as you might expect, of other bleeding disorders, being female, which may simply bring more people to attention who have more severe factor VII deficiency. But otherwise, many other factors were negative. Many polymorphisms or predispositions to mutations, variants within prothrombin, for instance, did not predispose to factor VII severity. And then Mark Skinner talked about a novel methodology in looking at data sets in the mild and moderate population, which tend to be ignored and not followed very well throughout the world, and suggested a different approach toward interviewing patients and collecting longitudinal data on them, rather than trying to go through a registry to capture mild and moderate patients. And he worked with a diverse group of experts in this field that were able to generate this type of a data set. And the talk really described it in some detail. It was also pointed out that it was patient-centered. The patients themselves had to provide much of the data. And then I'll finish with a talk from Lynn Malik that talked about first-time immune tolerance induction using factor VIII Fc and the final results from a global study. And so what she showed was a relatively rapid immune tolerance when patients were given factor VIII Fc. Within the first 10 to 12 weeks, the majority of patients did achieve tolerization, with additional patients coming along through the rest of the year. The estimate for ITI success was 67%, which is about the same as a number of other studies that have been shown. And so she concluded that this was the first time an EHL had prospective data for the development of ITI as a first-time therapy for patients, and that it was well tolerated, rapid time to tolerization, no relapse in most of the patients. And so that provides additional information for use of extended half-life products. With that, I will say there was a lot more there, and would encourage you to look at the abstract books for additional information. We will now move on to our next presenter, and I no longer have control. Thank you. Loshana.
Now Dr. Loshana has control.
Thank you, Glenn, and thank you to you all for joining in the session today. I'd like to thank the WFH for the invitation to be on the panel today and the opportunity to talk to you all about the dental considerations for people with bleeding disorders.
Loshana, you've just muted yourself.
Thank you. The objectives for this presentation is to give you all some insights into the importance of oral health and how it impacts on the quality of life of this group of individuals. I think it's fair to say that dentistry is not always widely provided or easily provided in many areas of the world, and my work with the World Federation of Hemophilia over the last 10 years or so has made it obvious that there is a variant care for our patients. So I want to also discuss about how we can help break some of these barriers, and also how the care team can facilitate access to primary dental care. And when we talk about primary dental care, we're really talking about the basics of dentistry. We're just talking about routine care, routine maintenance, things that will prevent patients from needing to have invasive advanced care. Sorry, it's not moving forward. Thank you. So restorative dentistry really has a wider meaning. We're not just about filling and replacing teeth that are lost and doing treatments. We're thinking very, very much about the perpetual preservation of the patient's dentition. And why that's particularly relevant for this group of people is that most of dentistry and dental disease is preventable. So the current guidelines from the World Federation of Hemophilia really are predicated on trying to help improve access to care for patients and making sure that most dental treatments can be carried out safely whilst minimising the need or the use of factor concentrates, because that can sometimes be the difficulty. And because patients can be safely treated in primary care for routine dentistry, it does mean that dentists can become confident in using local measures to manage bleeding. But if they don't see patients regularly, that can become an issue, and we can talk about that a bit later. What we do know is that really only severe bleeding disorders and those patients with inhibitors really do need to access care in a comprehensive centre where there can be better liaison and communication with the haemophilia team. So that really includes invasive dental surgery and extractions. We used to say that there is an injection called an inferior dental alveolar block injection that required factor concentrate, simply because it was given into a closed space near a very, very capillary-rich area called the pterygoid venous plexus, and having a bleed in an area that you couldn't see was quite dangerous. And the same for lingual infiltrations, because if you have a bleed in the submental region, that could impact on your airway. However, in the last few years, there has been more wide access to a different kind of local anaesthetic called articaine, and that really allows you to not need to have block injections or regional block injections. Articaine is very good at getting through bone and anaesthetising the teeth. So that has really reduced the need for patients to need factor concentrates for routine dental treatment in the lower jaw, where they would have previously had a block injection. So that's good for our patients. As I said, really, in terms of a really big take-home message in terms of dental considerations is that dental disease is preventable, so therefore prevention needs to be our priority. If we can have good prevention, then we can preserve a healthy dentition. And when I say periodontium, I'm talking about the supporting tissues of the teeth, so really the gums and the bone. And then if we have good healthy teeth and gums, we don't really need to have invasive dental treatments, which therefore means we reduce the difficulties that people face when trying to access care. It also means we have less complications for some of the more rarer diseases and also for patients with inhibitors. And of course, sometimes the cost is becoming part of the prohibitive factor. The thing that causes most bleeding in terms of oral health is gum disease, called periodontal disease. And it happens to be the most common chronic inflammatory condition in humans, affecting almost 50% of the world's adult population. There's a higher prevalence in the British population, and depending on what studies you read with your local epidemiological studies, you might hear quotes of sort of 50 to 80%, sometimes it's 50% in the USA, but other studies in the USA have reported it as high as 8. Simple procedures like brushing your teeth or cleaning or eating can cause bleeding, and that is an issue. Studies have shown that this, although it was a small number of patients, that there was a higher proportion of periodontal disease in patients with bleeding disorders, but actually a more recent systematic review has shown, particularly for von Willebrand's patients, that they're not more prone to periodontal disease, they're not more likely to get a greater inflammatory response. And that's really important to note, because if you read many textbooks, if you talk looking at the symptomology of a lot of the bleeding disorders, you will read things like heavy menstrual bleeding, nosebleeds, and oral bleeding. And actually, many patients, people with bleeding disorders, just accept a level of oral bleeding as part of their bleeding disorder, when it very rarely is. So understanding periodontal disease just might help you to help your patients. We know that it's common. We know that a very easy symptom that patients will experience is bleeding when they brush their teeth. So actually, very simple questions your patients. If they have prolonged bleeding, obviously with more advanced disease, that can be a problem. They might mention to you. Of course, tranexamic acid used as a mouthwash is very effective, and many studies have shown that. You could, if it's not available as a mouthwash in your local areas, then you can just ask the patients to crush the tablets and dissolve it in 10 ml of water, and it makes for a very effective mouthwash. You see on the screen here, this individual has got very inflamed gums, and you can see This, what I'm pointing to, is what we call the biofilm. It's the plaque that accumulates on the surface of the mucosa when you haven't got very effective oral hygiene measures in place. And so therefore, when you touch the gums or you probe the gums, they bleed. The challenges for the dentist is really that our way of very effectively managing periodontal disease is actually to help focus on improving the oral hygiene practices of the patient. And that's quite difficult to do if they're not going to see the dentist. But also when they do go to see the dentist, we need to remove that biofilm, which is where the bacteria that are promoting the inflammatory mediators and the toxins that make the tissue inflamed and to bleed easily, that actually causes bleeding. So we do need to revert to very robust local measures to help with that in terms of managing the treatment. And if you're not confident to do that, then that could make it difficult for the dentist or impact on their confidence. Let's look forward. Thank you. So this is the same case again, and what the point of showing this is not to show you too many gory pictures, but really to say that actually just if you look at the picture on the left, which is just after the cleaning has happened, and the picture on the right, that's literally just a week later when the individual comes back. Because of the amount of bleeding, dentists would normally divide the treatment into small areas so that they don't do too much in one go, and therefore there isn't a same level of challenge for the patient and hemostasis. But once the biofilm is removed and the patient is improving their home care, the tissues do heal, and therefore they then don't have issues with bleeding, because really, as you see again, healthy gums don't bleed. So the point to make here is that there isn't really any reason for individuals to suffer with chronic oral bleeding all the time and just assume that this is part of their bleeding disorder, because actually it can be very easily treated with some very simple intervention from a dentist or a hygienist. And why this is important, again, because it very highly ranks in general quality of life studies, and this is just one study, but there have been many studies over the years, and people do rate their oral health very highly impacting on their quality of life, because it isn't just the absence of pain from dental disease, it's literally the sort of other things that it's harder to talk about, or they don't have a forum to talk about if they're not going to see their dentist, which is the constant taste of blood in their mouth does affect their enjoyment of eating, impacts on their taste, their confidence, function in social situations, having about oral bleeding. Sometimes patients have said, you know, they could blood on their odour, so there's sort of bad breath, which can them. I beg your pardon, lost my connection. Intimacy, they don't want to talk about, and not really I beg. I do apologise, I'm not sure.
Well, Luciana, maybe go off video and see if that helps.
Thank you. Carolina, you have control of the screen. Would you please forward the next slide? Thank you. So really, because of the inflammatory nature of periodontal disease and the heightened sensitivity of your inflammatory system, there have been very weight babies and rheumatoid arthritis. And as we get better at looking after our patients and they're living longer, they are going to have some of these comorbidities that you may that would impact them, and their primary oral health becomes very important. Obviously, there's head and neck cancer, and the biggest risk factors for head and neck cancer is smoking, and smoking plus increased alcohol intake increases your odds risk ratio significantly. So I guess really, if it is possible to help with patients to have their dental home, as we call it, somewhere where they can access primary care, we can change the left-hand picture to become the normal for our patients as opposed to the right-hand picture, which can sometimes be the issues. So some years ago, we looked at undertaking a study to just look at what the barriers to accessing care were. And we had a survey which was completed online or when patients attended the Hemophilia unit, and we surveyed 105 anonymous patients over a 5-month period. And we also asked some local general practitioners, dentists, about their experience with individuals with bleeding disorders. And what we found was that actually 20% of patients had been refused dental treatment. Getting a bit mad now. And more unexpected was we noticed that there were patient-specific barriers. 17% of individuals had felt very apprehensive about visiting their local dentist, and actually 45% of them felt that their dentist didn't know how they would, weren't confident in their dentist's ability to look after them. And actually, this was borne out by the dentists also saying that they weren't confident in how to manage a patient, and that they wouldn't feel able to manage them if there had been a bleeding issue. But reassuringly, 90% of them did say that if they had some information about the patient's bleeding disorder, and they would feel more confident to look after them. So that's what we created, and this is really, I think this was on the WFH website for some time. I'm not sure if it's still there, but really this is a very, very important tool and the great communication, because I think this is definitely the key to success. The patients do come and see you in your clinics. They are confident to come and see you, so it's a very good opportunity to get dentistry as into the conversation and the review to make sure that they are accessing care. If you give them this letter that we use in my clinic is co-signed by Dr. Dan Hart, who's a consultant hematologist, and of course myself. It's addressed to the dentist, which means that the dentist sees the letter, sees what the disorder is and what they can safely manage, and what they should really refer the patient back to us for. It helps to educate and demystify the bleeding disorder for the patient, but it also empowers the patient to go and seek help, because actually they have a letter that says the dental consultant thinks it's okay for me to go to primary care, and so does my haemophilia consultant. But we've also trained our local team to ask some very simple questions. And just to finish off with my presentation is really to help have the conversation is part of the half the battle in the scenario. So this is our pathway. It's a little bit busy, but basically the patients come in, they get the dental liaison letter, they go to their dentist for their routine care and maintenance. And if they need the treatment, they can just get on with it. But if they do need some factor cover, they will have a fast referral to the system. But also if there are patients who are really struggling to access care, then they'll come directly to us. We have a North London haemophilia network. So we've got all of the patients, nearly over 2,000 patients in the area that can access this care if they are struggling to get it locally. But in terms of the really two big healthcare messages that you could help with your patient is to understand that the two most common dental diseases are dental caries and periodontal disease. So dental caries occurs when you have oral bacteria fermenting sugar or fermentable carbohydrates that produce acid, which destroys the tooth tissue. And so you can actually prevent caries by just explaining to the patient or the nurse team to say it's the frequency of sugar that actually causes the harm. Because your saliva is alkaline, it will naturally buffer the acid. And so therefore, if you're not snacking in between meals, the chances of getting dental decay are very low, even if you have a sugary breakfast and sweets for lunch and sweets for dinner. And gingival inflammation is caused by dental plaque, which is a biofilm. And that coats the surfaces of everybody's teeth, and everyone has this. And so it's a way of effectively removing it every day, twice a day. That's effective plaque control. What you see on the slide here is a very simple food dye that we use to show patients the plaque that's on their teeth. Plaque is very tenacious, it's white, you can't see it. So actually removing it is much harder. So if you can see it, that just helps the patient, and they can hope certainly in London, where you can buy this over the counter very cheaply. If patients do have problems accessing care, the proprietary things they can buy over the counter is fluoride. Fluoride is very good for preventing decay or slowing down the process of decay, because it makes the enamel harder and more insoluble to the acid produced by the bacteria. And Corsadil chlorhexidine is really a really effective mouthwash. It coats the surface of the teeth so that plaque can't adhere to it quite so well. So those that hope, just a couple of take-home messages really. I do apologise about my connection, but I'd be happy to take questions on the chat or later on if you wanted to ask me any specific questions. That would be great. And thank you for your attention.
Thanks, Luciana. There is one question in the Q&A for you already. It's now my pleasure to invite Bruce Luxon to speak on hepatitis and looking at liver health. Bruce, I should also mention, has been instrumental with working with us at the NHF, the U.S. National Hemophilia Foundation, and the Medical and Scientific Advisory Council over a number of years on helping to guide the organization on the best ways to manage individuals with bleeding disorders and their liver health. Bruce.
Thanks, Glenn. These are my disclosures. And here's the plan for today. I do want to spend a few moments talking about basic facts on treating hepatitis C. It's going to be a pretty shortened version, but I want to make sure that everybody knows that we have great treatment options that Glenn just mentioned and great success rates. And I want to spend the majority of the time talking about what happens after we get rid of the infection, because I can cure hepatitis C, but then how should you assess liver health? What are potential complications that you need to look from after the HCV infection? And more importantly, how do I know if the patient is at risk of these complications? So I'll try to answer all those today in the 15 minutes that we have. So I put this slide in because hepatitis C was known as the silent epidemic. It was, at least in the United States, the previously #1 cause of patients needing liver transplant, and it remains a leading cause of liver cancer. On the right, you can see one of the posters that the CDC put out about hepatitis C. It does not discriminate. It has affected millions of people, and it causes liver cancers. Very important to know about. So I have a typical patient that actually very similar to somebody I saw this last week. He was 56 years old. He's got hemophilia, and he got human-derived factor when he was a teenager. He got hepatitis C and was treated in the early 2000s with interferon, one of our old treatments, but was not cured. He was monitored with annual ultrasounds, and eventually got a direct-acting agent, the current medicines that we used, and he was cured then of his hepatitis C now 3 years ago. But while his hepatitis C is cured, what do I tell this patient? Because his liver disease is not really cured. And again, he wants to know, what are the complications of his liver disease? How do I advise him that we're going to monitor him? He wants to know where his liver improved and what can he do to lower his risk of complications. And this was his CAT scan. You can see a big spleen on the right of the slide and a very nodular looking liver. And I'm sure many of you have patients that fit into this category as well. So the CT scan again said he has a nodular liver. I got some blood tests that show a high probability of advanced fibrosis, and I'll show you some of those later. And a very simple test called the APRI, which is based only on platelets and AST, suggests he has a 91% chance of cirrhosis. And I think this is a very typical patient that many of you are taking care of. I had to include this slide because hepatitis C has recently been awarded. The folks who discovered the cure for that got the Nobel Prize, and I've had a chance to work with several of these. It's really brilliant science that led to the cure. I put this slide in to remind us that just a few years ago, we could not really cure hepatitis C. Back in 1991, as this patient, we gave some interferon, but look at the cure rates now. And over on the right-hand side, you can see there's basically nobody that we can't cure with hepatitis C giving our direct oral acting agents. So really impressive. The success rates do depend a little bit on which genotype you have, but as we've gotten smarter, we can cure almost everybody, whether it's genotype 1 or through 6. And as Glenn mentioned in his introduction, there's a wide geographic availability of access to treatment for hepatitis C, just like there is for treatment for hemophilia. So all these can be potentially cured. And there's no evidence that people with bleeding orders have different cure rates for hepatitis C than those that I've listed. So once you've cured the patients from their hepatitis C, what can happen? So I put in 3 pictures. This is a patient obviously with ascites. These are esophageal varices that are in the esophagus and can bleed, especially in patients with bleeding disorders. And the most dreaded complication is shown at the middle bottom of the slide, which is liver cancer. But sometimes nothing happens. So how do you decide the patient who's in your waiting room is going to have one of these complications or nothing? Well, I tell my patients that hepatitis C cirrhosis is like walking on a trail along a cliff. And where you are on the trail makes all the difference to your risk. And we as physicians want to be able to identify, is that patient like this person there standing really close to the edge, high risk? Or perhaps a little bit smarter, moving away from the edge and not at risk. So how do you do that? So to quantify liver health, we can use a variety of tests, but the traditional serum tests like liver enzymes are notoriously insensitive. We used to do a liver biopsy on everybody, and that was our gold standard. But obviously people with bleeding disorders, that was more challenging. But the good news is that now we have many non-invasive techniques, and I'll talk about some of those. There's innovative combinations of standard tests. I mentioned the APRI. There's specialized proprietary tests like FibroSure or FibroTest. And the new kid on the block is called Elastography, which is a specialized either ultrasound or MRI. And each of these tests are trying to answer where is the patient on the scale that I show on the bottom. Most people are familiar with this Medivir scale. It's a scale from 0 to 4. And the challenge is that if you are in stage 3 or stage 4, that's where the complications occur. The first 3 stages, 0 to 2, very unlikely. You are far from the cliff. So you want to know, is that patient in stage 3 or 4? So here's my patient again. He says, how's my blood test doing? Now he's 3 years out for his cure. His AST is now normal. His platelets have risen. And he still has a high likelihood, but improved chances that his liver is getting better. And again, he wants to know, when will I get better? So we have a lot of evidence that we can encourage people that they are going to get better. This is an old biopsy slide showing a very cirrhotic liver on the top left before treatment. And 4 years after cure, we rebiopsied this patient. This is not a patient with hemophilia, and you can see the scar tissue's gone. So we do know that curing the hepatitis C in most patients will lead to an improved biopsy and improved liver. So this is really old news. This slide shows you studies that were taken nearly a decade ago, and I highlighted in the circle one of the biggest ones that Terry Poinard had done in 2002, now 20 years ago. And he showed that 67, 2/3% of patients who had cirrhosis would get better over a period of 2 years. So again, we know that that can happen. It's very encouraging, but you still have to decide, is the patient in front of you going to be one of those? So I want to spend the last little bit talking about specialized lab tests. As I mentioned, there's a variety of those. They can be using values that are standard things like platelets, AST, or more unique lab values such as matrix turnover proteins. Some of them can be combined into a fibrosis score. You need to make sure that there's a disease-specific one. There's one specifically for viral hepatitis. And again, they predict the probability of advanced fibrosis or the likelihood of minimal fibrosis. And most of these tests, if they're commercially successful, correlate with the Medivir scale that I had showed you earlier. Here's just a list of some of those. They are variably available. Some are available in Europe, but not in the United States. Some are available in different countries or covered by insurance differently. I would encourage you to pick a few of them, find out which ones are available through your local labs, and get used to ordering them. I gave you one example here of a non-invasive fibrosis test. This one happens to be the Fibro Test. And so the patient that I got this from had a score that's shown there on the left in the purple bar with the red arrow pointing to it. And that correlates with F3, which is advanced fibrosis. So he's at risk. Some of these other tests also tell you how much activity is going on in the liver, how much inflammation is there. This person had very low inflammation. So again, my advice is pick a test, get used to it, and try to determine if your patient's at high risk or not. This patient is. And the new kid on the block is elastography. It is a very popular method. It's non-invasive. It uses a sound wave that it samples a rather large section of the liver. It's easy to do in the office. It gives you instant results. The physiology and the physics is that it measures the speed of sound through the liver. The speed that the sound wave goes is proportional to stiffness, and the stiffness is related to the fibrosis. And when that's all said and done, it gives you a stage of fibrosis that I've shown you before. And again, your goal is to see, is your patient at stage 3 or stage 4 and at higher risk? So I hope I've convinced you that hepatitis C, the fibrosis, can be reversed. Even cirrhosis can be reversed, but unfortunately complications can still occur. I've shown you data that can, I hope, convinced you that early changes and improvements can be seen as early at 1 year, and 5-year benefit is clearly seen even in cirrhotics. So the next couple of slides, I want to summarize what I want you to take away from my section of the talks today. For patients with confirmed advanced fibrosis or cirrhosis, they have a high risk of liver cancer. Our current guidelines, both in the US and Europe, are to screen with an ultrasound every 6 months. They're at high risk of variceal bleeding. Do an upper endoscopy by your GI colleagues every 1 to 2 years, and then look for the complications of ascites and encephalopathy. If you have a patient with advanced fibrosis or cirrhosis, it's important to determine if they're still at risk or if they've gotten better, and use a combination of blood tests and elastography. My personal preference is I do that every year or year and a half. Patients want to know, how is my liver doing? So in summary, treatment of hepatitis C is now very routine. There are multiple oral regimens out there. We can cure almost everybody if we can get them the medications. I want to remind you that curing the viral infection does not, however, cure the liver disease, and patients can still have complications of ascites, variceal bleeding, and the dreaded liver cancer. It's easy to determine, relatively easy, I should say, the extent of liver fibrosis. You can use blood tests, elastography, and patients who are listed to have advanced fibrosis on the Medivir scale F3 or F4, they are the ones who are risk for complications. And finally, I think it's very important, just like you've heard our previous speakers talk about making a partnership. If you have somebody with advanced liver fibrosis and is at risk of complications, please find a hepatologist who feels comfortable taking care of your patients, and especially if gene therapy as a research protocol is an option. Thank you very much, and I'll turn it back to Glenn. And I suspect we will have some time for questions, and I thank you again for your attention. I hope I've taught you something about liver disease. Thank you.
Julia, is Cedric on? Do we know?
Yeah, Cedric, if you want to, there he is. And if everyone wants to put their questions in the Q&A, we have a time for a couple now.
So do I take care of the questions myself, or is Glenn doing that?
It looks like Glenn has left already. So Cedric, if you could handle that, that'd be great.
Okay, so I'm checking all the questions that we receive. So Bruce, a question to you about the alpha fetoprotein assay or test. So one of our colleagues is asking about, you know, the value of this assay to screen for hepatocellular carcinoma. Could you elaborate a little bit on this?
Sure, be glad to. Thanks, Cedric. So alpha fetoprotein is a protein that is made by rapidly growing liver cells, hence the name. It is recommended to be used only in conjunction with imaging, because there are a lot of false positives, low levels of alpha fetoprotein, but I think more importantly, many cancers don't make it. Many liver cancers don't make it, and so you can have a liver cancer and have a perfectly alpha fetoprotein. So the EASL guidelines, the European guidelines, and the American guidelines say you can use it in conjunction as an additive to the ultrasound, but not alone because of the issues I've said. I personally check it. Again, for screening, it's cheap, it's paid for by most insurances, but I make sure that I use it with an imaging modality as well. Thank you.
And how frequently would you check the AFP level? Also once every 6 months for the ultrasound?
That's correct, Cedric. We recommend once every 6 months for patients who are at the high risk that we've talked about.
Okay. Maybe, Luciana, a question to you. So how frequently should the patient be referred to the dentist for, optimal follow-up, I would say?
Thank you, Cedric. So really the guidelines for implementing best sort of regime of prevention would be every 6 months. And that's for children who have a high rate of decay and disease every 3 months. Cedric, there was also another question, if I may take that, that I can't actually see in the chat group.
Yes, take it, please.
One of the attendees asked about the name of the injection that avoids the need for a block injection, and that's articaine hydrochloride. And I'll write it in the chat if I can. It's 4% and it also has epinephrine in, so it has that vasoconstriction effect that also helps with hemostasis. Thank you.
Mm-hmm. And Luciana, would that be different for patient, irrespectively of their disease severity? So clearly severe patients are probably at high risk, but what would be your advice for patients with mild and moderate hemophilia A or B?
In terms of the frequency of recall?
Yeah.
So that would depend on their dental status. So if you had a patient with very low levels of disease, very few fillings and good oral hygiene practices, an engaged patient, then you can do that once a year. The standard protocols for somebody who has fillings that and sort of decay from time to time or bleeding gums would be every 6 months.
Mm-hmm.
The most you should really live, even if someone has a completely unrestored dentition and no gum disease, 2 years would be at a push.
Mm-hmm.
That's simply to catch dental disease when it's early, when it's easy to manage, when it doesn't require any invasive treatment, and so the management is more easy for them to get without bleeding issues.
What we do here, I'm not dentist, I'm hematologist, but what we do during a review clinic, we make sure that the patient that they have been seen by the dentist recently. So, and if this was not the case, we make very clear to them that this is very important. And I think this is what most hematologists should do. I think we concentrate a lot on the joints, on replacement therapy, and we need to make sure that our patients have been seen by the dentist recently. And I think it also applies to you, Bruce. We need to make sure that someone has paid attention to the liver. This is important. Recently, again, we discovered a few patients, even with mild hemophilia, who had not been seen in hemophilia treatment centers for many, many years. And so, everyone, nobody really paid attention to their hemophilia. So when we checked them, we realized that they had Hep C. And I think this is very important. We need to make sure that all our patients with hemophilia, even the mild ones who might have been exposed to blood products, sometimes decades ago, they've been screened. Do you agree with this? Because that would be a pity to lose patients in the future just because they've not been screened.
Oh, I agree completely. In fact, yesterday in my clinic, I had a referral, exactly what you described, Cedric. We have a very good hematologist here, hadn't seen the patient. He's got hepatitis C, and I can cure him. It's so easy to cure him and prevent all these complications that we've talked about. And so screening somebody for hepatitis C is now, at least in the US, nationally recommended one time regardless, but certainly patients with bleeding disorders should clearly be screened once. In fact, everybody should be screened once. It's a simple antibody test. It's covered by insurance. And then find your favorite hepatologist and send the patient to see them.
Yeah, and I think this is valid for patients with hemophilia, von Willebrand disease, any other kind of clotting factor deficiency, and also hemophilia carriers, because some carriers with clotting factor deficiency might have received blood products sometimes many years ago and never been screened. So I think this is important too.
Absolutely.
Okay, so are we getting more questions? Just checking here. Well, about maybe this was a questions to Glenn, but Glenn is not longer with us. So that was the questions about ASH and about the AVEN6 study. So the AVEN6 looked at patients with mild and moderate hemophilia, and the question that was asked is whether higher concentrations of immiscismab were given to these patients. Well, as far as I remember, this is not the case. The patients do receive exactly the same treatment regimen as severe patients. So there was no reduction in the dosing regimen in this patient. Other question? I'm not sure. No, I think, we are getting a lot of very positive messages of colleagues around the globe who did really appreciate your talks. So this is great. I think we will now be in a position to move to the next session. Okay. So now I checked again. No more questions. So Bruce, Luciana, I would like to thank you for your great talk. Please stay with us.
Thank you.
Okay, thank you very much.
Our pleasure.
And,
Thanks, Cedric.
Thank you to both of you. These were important topics. So the next topic will be given by me. During the next 15 minutes, I will focus on obesity. And then we'll have another talk about pain, but we'll present the other speakers later on. So a few words about obesity and hemophilia. Next slide. Yeah, well, this slide shows you that obesity is a problem. Many of our patients are overweight or obese, and you can see here data. These are all data, but I think they reflect the reality, showing you what the situation was in 1992, in 2001, 2009, and not only in the United States, but also in the Netherlands. So clearly, there is a significant proportion of our patients having weight problems, either overweight or obesity, and that proportion has increased over the last few decades. Next. And these are again data from the Netherlands showing you how the situation has changed between 1992 2001, and that was true for adult patients, but also for younger patients. So clearly a problem for the entire hemophilia population. Next. And these are data from the United States looking at the body mass index, the BMI above normal level in children, teens, and adults, the obesity and overweight. So as you can see, many of our adult patients have this kind of problem, but this is not limited to adult patients. Next. And this is a very busy slide. There have been many studies looking at this in different parts of the world. And clearly they show that a significant proportion of our patients do have obesity. But I don't have time to go into all the details of this slide, but the proportion is more or less in line with what you see in non-hemophilic population. And this is true for overweight, and this is true for obesity in different parts of the world. So this is not a specific disease for patients with hemophilia. Yeah, next. So why do our patients with hemophilia develop overweight or obesity? So does hemophilia itself predispose to obesity? This is an important question because what does obesity means? Well, obesity means that there is more fat and also less muscle. And as you can see on the slide, it's very likely that our patients with hemophilia, because of repeated joint bleeds, are more inactive. And that could increase their propensity to develop obesity. And obesity, again, will increase the pressure on the joints and precipitate joint bleeds. And there could be some sort of vicious cycle linking hemophilia and obesity. But is this true? Well, probably not completely. As you can see on the right part of the slides, there are many barriers for patients with hemophilia to initiate or maintain weight loss problem. And this is part of a publication recently, recent publications in hemophilia. I'll come back to that later on. Next. Another issue is that in many centers, in fact, doctors, nurses do not probably pay enough attention to this, what we call morphometrical variables, because the body mass index should be calculated. That means that you should measure the weight of the patients, calculate the BMI. I think this is important, and this is not always done. So as a patient, you should make sure that your hemophilia treater is paying attention to that. And the other issue is that even if the BMI is calculated, well, its value should be communicated to the patient and discussed with the patient, because it's very important to make sure that the patients are completely aware, informed about their body weight, and if their body weight is inappropriate or the body mass index is inappropriate, they should receive proper information about this. Yeah, next. So what are the consequences of obesity? Well, there are numerous possible consequences. Physical, certainly. Well, as you can imagine, increased body weight means more pressure on the joints with a decreased range of motion, impaired joint status, impact on physical functioning of the joints, also multiple comorbidities. I'll come back to that, and also an impact on coagulation. And I will share with you some information about this physical comorbidities and blood coagulation implications of obesity in patients with hemophilia. Next. So what are the consequences? Clearly on the joints, the range of motion could be negatively impacted. This is clear. The bone health, by contrast, could be improved because it has been shown that obesity could be associated with an increased bone mineral density. Patient could have greater muscle strength and less joint pain, although they have obesity. Cardiovascular health will be negatively impacted with an increased risk of atherothrombosis, increased PI, I'll come back to that. Clearly liver problem, and we know that accumulating obesity and Hep C is certainly something that should be avoided. And also on the pharmacokinetic of clotting factor, and I'll come back to that. So many, many consequences. Next slide. So this slide shows you, I will not go into details, but you need to show that there are good data showing that the obesity will worsen the range of motion of different joints, and also specifically the hip joints will be negatively affected by obesity. And that has been extensively studied in very good studies published over the last 10 years. Next. With respect to the bleeding phenotype and bleeding tendency, although patients with hemophilia do bleed, as you know, for many reasons, well, in fact, patients with obesity could have a bleeding phenotype that could be influenced by that, because patients with obesity do develop what we call hypofibrinolysis. So that means that they dissolve the clot much less easily than other people. So their clot could be much more persistent, and that could impact on the bleeding phenotype. So patients with obesity are certainly at risk of thrombosis, and this thrombotic tendency could to some extent reduce their bleeding phenotype. Yeah, next. Do obese patients with hemophilia consume more clotting factor concentrate? Next slide. Well, we have some data from the Netherlands showing that clearly patients with hemophilia use more concentrates than others. I will not go into details of this slide, but that has been well demonstrated as in this kind of study comparing approximately 50 patients with hemophilia. Yeah, next. And in fact, they overuse concentrate, or they use more concentrate, on average 40%. So in Western Europe, that could mean up to 6,000 units a month. This is significant. And that happens while these patients, in fact, do not have more clinical bleeding episodes than patients without obesity. And that could be explained by the fact that these patients could have a higher level of sedentarity, they might be overtreated. And as I said, their clotting system might work a little bit differently because of their obesity. Next. So is it useful to use more concentrate in patients with hemophilia? As you know, the dose that you calculate, yeah, you could, if you could share this animation with me. So if you need to calculate the dose of concentrate in these 4 patients, as you can see, it will range from 2,400 to something more than 4,000 based on the body weight. But does it make sense, especially for factor VIII? Because as you know, to reach, let's say, 80% factor VIII in these 4 patients, based on their body weight, so you will calculate and then divide by 2, because you know that the factor VIII will remain in the intravascular space. But does it really make sense in obese patients? Next slide. So if we had these 3 gentlemen suffering from hemophilia, this is not the case, but should they be treated the same way? Probably not. Next slide. So this is one of my patients with certainly obesity, body weight of 120 kilo, body mass index of 38 kilogram per square meter. And as you can see, this patient received approximately 2,000 units of factor VIII. And with this small, well, with this 2,000 units, his factor VIII level range moved from 11% to 56%. So we could calculate the recovery, and in fact, it was not 2, but 2.75. So much more than expected. So that means that, in fact, with patients with hemophilia A treated with factor VIII, their factor VIII behaves a little bit differently. Next slide. And as you can see on this slide, when you give factor VIII to a patient, this factor VIII will not distribute in the entire body. Factor VIII will remain in the intravascular space. And we know that the size of the intravascular space is influenced by age. So clearly, if you calculate the dose of factor VIII on the basis of the body weight, you could overtreat patients with hemophilia and obesity. Next slide. So, and this topic was discussed at the last ASH meeting last week. So there was a nice communication about this. So how should we treat our obese patients with hemophilia A in particular? Next slide. So that has been extensively studied. And one of my co-workers, Séverine Henrard, dedicated a huge part of her PhD thesis a few years ago to that topic with very important paper on this aspect. Next slide. And what she did, she compared the recovery of factor VIII in different populations of patients with different body weights. And she found that the recovery, instead of being 2, well, ranged from a value that was low, 1.88, to something around 2.7. And that was found in adults and children. And these data were more recently confirmed in another study. So clearly the obese patients have a higher recovery than expected. Next slide. I will skip that one. There is a short animation to save time. Yeah, next. So clearly, if you do not rely on the body weight, what should you use? So as you can see on this slide, there are very parameters that could be used. Well, probably the ideal one should be the ideal body weight, or that you should use to calculate the dose of factor VIII for patients with hemophilia A and obesity. Next slide. And if you do this, so if you use the a recovery that has been adapted to the body weight, it's clear that you will be able to reach a factor VIII level that you expect. So instead of reaching very high levels, as you can maybe move to next slide, you will be able to reach a peak factor VIII level around 100%, and the half-life will not be modified. So I think it's important in 2021 not to overtreat obese patients and to take into account their individual PK. Next. The problem is that many doctors don't do that. Many doctors still prescribe factor VIII for prophylaxis on demand or for invasive procedure, just relying on their actual body weight and not the ideal body weight. So practice should change over time. Yeah, next. I will skip this one to save time. You can skip. Yeah, and there is a very interesting paper that was recently published in Hemophilia about what should we do. And well, clearly in that study, next slide, they found that, again, that was another confirmation that among all the PK parameters, well, clearly the recovery is affected by the body weight. but you need to know that the half-life is not significantly modified in obese patients. So obese patients do clear factor VIII at the same rate as non-obese patients. So we have strong data supporting this. Next. Another problem with obesity is that many patients cannot self-infuse. So they have many problems with venous access. So this is also something that we should address with the nurse. And this is sometimes quite complicated. And as a result of this, many of these patients cannot follow strictly their prophylactic regimen. So that is an important issue too. What we need to do is to increase the awareness about obesity in our community. And a nice study was recently published in the States, and I do invite you to read this carefully. Next. So what should we do? Well, I think that all patients with overweight or obesity should be identified, that we should measure the BMI, that a nutritionist should be part of our comprehensive team. And if we realize that there are problems with our patients, that they are physically not enough active, our physiotherapists should be involved and help our patient in this weight reduction program. I think this is very important. Physiotherapists can here play a very important role. Next. I will skip that one. Yeah, I think it's important not to forget that patients with obesity have more fat, but not enough muscles. Yeah, next. And clearly our patients with hemophilia, certainly the older patients are probably not enough active, not enough physically active. So physical activity should be promoted. It's not always easy to stimulate or motivate our patients to lose weight. It's much more motivating and stimulating to help them to gain or to develop their muscle mass. Next slide. And I think this is an important issue. Our patients with hemophilia not only have a lot of fat or are sometimes too obese, but at the same time, you know, their muscle mass is not enough developed. And this is for many reasons, and this is clearly illustrated on this slide. So what we need to do, we need to help our patient to lose fat and develop muscles. So fight again what we call sarcopenia. Next slide. Yeah, I will skip that one. Okay, so to conclude, well, clearly obesity is a major concern among our patients. It has negative influence on physical functioning. It has an impact on the factor consumption, but as I emphasized, patients should be prescribed the right amount of concentrate considering the specific behavior. Maybe during the discussion we should elaborate a little bit on what we should do for patients treated with factor IX and immiscismab, and clearly we need more research in that area. So I'll stop here for the sake of time, and now we will keep all the questions at the end. And the next speaker now will be my my Belgian colleague here, Professor Nathalie Roussel, who is Associate Professor at the University of Antwerp. And Nathalie has really developed a major expertise in the management of pain in patients with hemophilia, and she will now share her great experience with you about pain and pain management. Nathalie, I give you the floor for the next talk.
Thank you, Cedric, and thank you to the WFH to organize this session. I think it's a great session. So indeed, my talk will be about pain in people with hemophilia. And what is it? Why do they develop pain, and how can they cope with pain? Doesn't function. I see the mouse. Okay, perfect. So the management of pain in hemophilia received little attention until now. When you compare the different hemophilia treatment centers, research or questionnaire came up with this conclusion that there is a need for a better understanding of pain and a need for treatment recommendations. But we cannot give treatment recommendations if we do not evaluate pain well before. It seems that I have a problem to manage the slides. So this is something I think you're all familiar with. Pain can occur during acute bleeding, but pain can also be a manifestation of a more end-phase arthropathy where the joint is impacted. But in the past, we have linked acute pain with bleeding and chronic pain with joint arthropathy, although these are not synonyms. Next slide, please. Okay, so what we know from other joint problems is that pain intensity can vary across a day or during a day. And in patients with osteoarthritis, we speak about a flare-up because pain intensity can vary a lot. So it's not correct to consider an increase of pain as an acute pain and hence as a bleeding. Next slide, please. So the cause of pain, it's much more complex than just differentiation, bleeding and joint damage. And again, it's a challenge. We can use ultrasound in treatment centers where ultrasound is present. But again, it's more complex than that because a lot of systems in our body will play a role in the interpretation of symptoms related to pain. And the purpose of this talk and the talk of the next speaker is to gain more insight in what could be maybe influencing pain and what can be dealt during management. Next slide, please. Okay, so pain is not the only symptom. As you know, the joint is impacted, so we can have decreased mobility, decreased muscle strength. We can have problems with articular cartilage. But what is maybe new for people that are not familiar with the evaluation of pain is that there is also something like sensitization of the nervous system. And it starts with release of inflammatory mediators, but the consequence is that there is an increased pain sensation. So it feels like it's more painful. It's like you can compare it with an acute burn. The skin is red and it's sensible to touch, although touch is not a dangerous stimulus. And that's what's happening in patients with osteoarthritis. So they are more sensitive to pain. Next slide, please. And that's the reason why we speak about a kind of pain cycle, because it's a kind of vicious circle, which with physical symptoms like muscle spasm or muscle hardening or restricted movement and muscle weakness, but also a functional problem, because people are not able to go up in stairs or have their activities of daily life, and that might lead to frustration. And in the right side, you see how this vicious circle may alter their quality of life, including their quality of sleep. Next slide, please. So we really speak about the complexity of pain, because of course it starts with probably a message of danger in the periphery. It might be a bleed, but it might also be a flare-up of the joint arthropathy. And this symptom will be, I would say, given to the dorsal horn in the vertebral column. It's like a transmission of information, and this information will move up to the brain. And it's only when it arrives in the brain that you have a sensation of pain. So pain, it's only apparent when you have information that is going to the brain and that is interpreted by the brain. So if the question is it in your head? The answer is yes, because you have your brain in your head, and the brain is the main system that is dealing with interpretations. And you see that the message coming from the, in this case, the food, has a long pathway, and you can have many influences. For example, in the dorsal horn, you see that there is a connection between the first order neuron and the interneuron that is going to the brain. So it's the line in red. And this synapse can be influenced by many factors, including a descending pathway coming from the brain. Next slide, please. So indeed, we speak about complexity because interpretation will be influenced by many factors, including talking about pain, previous experiences of others, but also by emotions, positive emotions, but also maybe negative emotions, and thinking about the pain will add to this complexity of pain. So what we would like to say to our patients is that perception of signals can be unreliable, because in the left side you see two boxes with a letter in it, A and B, and it seems as if the color of the boxes is not the same. But if you look at the right side, you see that the vertical gray line is apparent and it's exactly the same color. And it's a kind of perception bias, because you have the shadow of the green block, but you also have the color of the letter itself, which might be different, so that it looks like a different color, but in fact it's the same. And that might be the problem in some patients with chronic pain, is that the brain is misinterpreting signals. Next slide, please. So that brings me to the pain assessment, and it's quite important to say that under assessment of pain is a cause of inadequate pain management. If you only assess pain intensity, you are unable to establish a proper pain management. So pain, we know that it's a subjective experience, but it's also multidimensional. So that means that the assessment of pain should include both physical but also psychological assessments. Let's have a quick look at the patient's history as first. And here, literature doesn't help us in differentiating the cause of pain based on the subjective evaluation, because previous research has shown that the symptoms of bleeding and of a flare-up are quite similar. And we know that some patients are able to distinguish both, but many patients and also many healthcare providers are unable to distinguish the cause of the pain only based on the subjective evaluation. So the increase of pain intensity is not a good signal to say something about the cause of pain. Next slide, please. So here you have a table in which you can find some relevant questions. Next slide, please. It's maybe more for keeping if you have a pain assessment to do, so that you can inspire you. But all these factors can influence the pain experience of the patients and can also help us with pain management. Next slide, please. We have questionnaires. The majority, I think, you're familiar with. It's only unidimensional pain scales. So these scales are maybe usefully researched to quantify the pain intensity, but they do not say something about the cause, and they do not say something about how the patients experience pain in their daily life. You might have a patient with a VAS score of 4 or 5 out of 10 and having major troubles during work and relationships, and in another, it doesn't disturb this one. So pain intensity is only part of the picture. And here you see a body chart. You are all familiar with that. But what I would like to show you is a study that is done in patients with low back pain on the right side. And you see that the back region is colored in red. It means that the majority of the patients indicated their back pain on that spot. But some patients also indicated other parts of the body as being painful. And this is something what is being researched at this moment in the Clinique Universitaire Saint-Luc in Belgium, because we suspect that patients with hemophilia also have different pain locations and maybe not only the target joints. So this is something that is currently being examined thanks to different research grants. Because it's important to know the extent of pain. And you see that if all colored parts of the body are painful, we speak about a large part of the body. Next slide, please. Finally, one questionnaire that I like to use is the illness perception questionnaire. It has also been used in patients with hemophilia because it says more about how the patient copes with pain in his daily life. And that's also something we can discuss during the management, but that's something we need to evaluate first before going with treatments. I will not go into detail about all these other stuff, but do not forget that pain can influence the quality of sleep. So maybe ask the question to the patient, also the activities of daily living. What's the most difficult activity for you? And that's also part of the evaluation that will help us to establish a proper treatment plan. I will move on to the pain management part, and that's really difficult because it's not easy to draw a picture based on a couple of minutes. And you see that it's really important to have a multidisciplinary team, and that's a good thing of hemophilia treatment centers, that you have different disciplines that are in working in these centers. But I think for the chronic pain management, it's really important to also discuss aspects with the psychologist, with the physio, maybe with the occupational therapist, but also with the nurse, who can be a key figure in the pain management plan. So this is the ideal approach, that you have an extensive pain assessment, that you have a pain management strategy that consists of advice and explanation, but also physiotherapy, active movements, painkillers, and maybe in the long-term surgery if it's a chronic joint problem, but that you reassess the effect of the pain management, and if necessary, that you change your strategy. Next slide, please. Okay, so just to cover briefly the 3 domains, the pharmacological treatment, next slide. These are established based on non-cancer pain patients, but these haven't been examined in patients with hemophilia. So if we speak about the lack of research, I think research should establish the effectiveness of these pain strategies or pain management strategies, pharmacological ones, in patients with hemophilia. But for the moment, it's the best we can give you. The non-pharmacological treatments, yes. So that's the collaboration often between physiotherapists and psychologists, because when it comes to pain, you also have maybe sometimes fatigue or stress, or maybe a lack of motivation, or maybe anxiety to load the joint. But we know there is plenty of evidence showing that active treatment will decrease the pain. But the first question is, how do you motivate your patient with pain and with impacted joints to load the joint? Next slide, please. So if we speak about research, one study looked at the main predictors of positive treatment outcome in a variety of chronic musculoskeletal pain patients. And these were the 4 predictors, and you will see as number 1, physical activity. And that's not surprising, because physical activity will activate the blue line you see in the red picture, in the picture on the right. And this blue line, this descending pathway, can influence the activity of or the transmission of activity in the dorsal horn. So you can consider this blue line, this descending pathway, as a kind of own painkiller system of the own body. And it's a marvelous system. It can function very, very well. In some studies, they estimate the effectiveness as 60 times higher than the highest morphine we know. But you know, we need to do physical activity to activate this descending pathway. Depression and pain catastrophizing, these are, I would say, more psychological aspects, but they also have an important influence. So if the patient is depressed, or if he or she is ruminating, it will not help. So we need to tackle that during the pain management plan. And lastly, it's important to also show the patient that self-efficacy is part of the pain management plan. And self-efficacy, it's like saying to the patient, you can do something yourself. It's like the opposite of fatalism. Next slide, please. So I think this sums up what I do with or discuss with my patients in the pain management strategy. Of course, it's embedded in a cognitive behavioral approach, certainly when you are dealing with patients with chronic pain, which is the case of many patients with hemophilia. Stress management is part of the plan, but also the science of exercise and activity time. It's really important, and we now have also evidence that physical activity is well tolerated by patients with hemophilia. But we need to monitor them, we need to motivate them, we need to coach them, but it's possible. And we can use physical activity as part of the pain management plan, as long as it's an individualized approach. Next slide, please. So which are the take-home messages? The pain evaluation is much more than just evaluating or assessing the pain intensity or the cause of the pain. And as you know, pain is multimodal, so it means that many different factors can play a role. And what is not mentioned in this slide is the genetic part. It probably plays a small role as well, but what we do know is that structural damage, inflammation, but also deconditioning, and in my case, altered central pain mechanisms. It's a dysfunction of the brain that plays a role in people with chronic joint diseases, and these altered central pain mechanisms, we are studying them now in patients with hemophilia in a large study. Until now, 96 patients have been assessed, so the results will follow soon. But also, and it has been brought up by Cedric, overweight and sedentarity, it can play a role in the pain assessment. Next slide. So just to highlight what we can do in the pain management, it's to tackle part of these one. If, for example, surgery is not indicated at the moment, then we can start with a brace, but we can have a pain management consisting of medication, lifestyle changes. We can desensitize this altered central hypersensitivity, and we can prescribe exercise and physiotherapy. Next slide, please. This is a slide just to thank all the sponsors that made research possible, and I give the word back to Cedric. Thank you.
Thank you, Nathalie. Thank you for a great talk. And now let's rapidly move to the last topic, which in my view is highly complementary to the previous one. The purpose is to address the important topic of mental health in our patients with hemophilia, and that will be done by Kate Kerr, well known to most of you. She used to work as a nurse at the Great Ormond Street Hospital in London, a major center for hemophilia care in Europe, and she has been involved in many initiatives. I don't have much time to go through them. She is also currently the editor-in-chief of the Journal of Hemophilia Practice. So, Kerr, I give you the floor for the last topic of the day before we answer the questions.
Thank you, Cedric, and thank you to the WFH for asking me to talk about mental health and people with bleeding disorders. But I'm also going to talk about their family members, because actually they are really important as well. These are my disclosures. So if we think about the day of diagnosis of a baby with a haemophilia or any bleeding disorder, that comes as a shock, even if you know in your family that you have bleeding disorders before. And we know that in haemophilia, about 90% of the mums of those newly diagnosed baby boys will be carriers. But we need to remember that 30 to 50% of them have had no previous family history. And that even in those who know that they're having a baby boy and know that they're haemophilia carriers, can be described as a loss, because this is not the child that they thought they were having or the child that they thought that they had. And we'll come back to talk about how important that thought process is later. There's a lot of literature written about maternal guilt and how mothers blame themselves for having children with haemophilia. And I think as healthcare professionals, we need to be much more forthright about the fact that it is nobody's fault. That actually haemophilia happens, other bleeding disorders happen. Whether you carry the gene or not and pass it on to your child or not is not your fault. And we don't talk about the concern and the anxiety that men have when they pass on the haemophilia gene to their daughters. So we need to give mums a break. There is also some cultural need to have the normal, in inverted commas, son, particularly in some families with haemophilia. And there's a lot then to be done about learning to live with the child that they now have, which might not be the child they thought they were having, and the impact that that has on them now immediately, and how that is going to be as they move forward. And here's some work that has been presented by Linda Marion Westenson in Scandinavia, in Gothenburg in Sweden, who's done her whole PhD on parenting a child, and in her case with haemophilia. But it's the same, I think, whether you have another bleeding disorder. And she says that mums move from a state of being sad and guilty, there you go, we're blaming ourselves again, with the situation that they're in, and that gets better with the time post-diagnosis. So the further on from diagnosis you are, the less they feel sad and guilty. They reach a turning point at some point, and that is then a reconciliation of their changed life. And I think that's where we're seeing mums in the hospital most often, and we're teaching them about the bleeding disorder and about teaching them, their children about their bleeding disorder and starting treatment. That's mostly mums that are doing that. And she says that the fathers have a much more torturous road to being a capable father, they're sad, they feel powerless. Quite often we don't see them as much. They've gone back to work, they're not in the haemophilia centres so much, and they're not getting the support. They lose that regular fatherhood. So every man's baby boy is going to be the next major football player or cricket player, and they lose that when they think their children can't do sport. And they don't understand the treatment so much because they're not there having that education. So as healthcare professionals, we need to think about how we engage the fathers more. There's quite a lot of work done about parental distress, so how the child is behaving. As Natalie's just said, if your child is in pain, that is going to cause you as the parents emotional stress and emotional distress. There are also financial concerns around transportation, maybe having to give up work, sacrificing the income that you had to turn your key skills towards the medical management of your child. There's quite a lot of out-of-pocket expenses with having a child with a bleeding disorder, which might be going backwards and forwards to hospital for treatment, but it might be that you have to buy different things for that child than you had hoped that you would do. We know that in children with haemophilia who have inhibitors, that is much worse, and that's usually because they're bleeding more and the treatment is less reliable, and there's that unpredictability of what's going to happen to your child next. And here the mothers report much more personal pain than fathers, and presumably that's because they're at home more generally than the dads are, and they're seeing their child suffer with the bleeds and the pain. And there comes this point of normalisation where living with your child with a bleeding disorder is integrated into daily life. And that is not just about having prophylaxis, it's about accepting the condition that your child has and the limitations that that might put on not only your child, but you as a family. And we think prophylaxis is perhaps the ideal for parents, and we've got that newly diagnosed baby with severe haemophilia, we've started them on prophylaxis, and we've sent the parents off to get on with living. And actually the treatment itself could be a burden, and the parents often feel unsupported at home, and they're sort of a little bit lost because they're expected to get on with things by themselves. And that is all really a big treatment burden, and there's a lot of work being done at the moment about treatment burden, and the next few slides will discuss some of that. So this is the BBC study, the Burden of Bleeds in Children with Haemophilia study, and here there was greater burden seen in the caregivers of children who had joint bleeds, who had target joints or reduced range of movement, had a current inhibitor where the burden was significantly higher, and that was associated not only with treatment but with more hospital visits and admissions, and worse for those parents who had children living with chronic pain. 2/3 of parents reported that haemophilia affected their life. I think that's quite interesting. The other 1/3, what's different about them? I would have thought haemophilia impacted on everybody's lives. But about 1/3 reported an economic impact. And this study was done in Europe across centres where, countries where there was good financial support for people who had children with long-term conditions. So imagine if you're in a less well-developed country or you have no social support, that's very difficult. And interestingly, caregivers lose a lot of time from work due to their child's haemophilia. So some of them said that they were spending between 8 and 14 days a month not able to fully work, and they were spending greater than 5 hours per month infusing and greater than 3 hours per month travelling to the haemophilia treatment centres. You might think that that is predominantly in small children, and here's a different study. This is the CHESS Pediatric study, looking at the hours of care provided per week by parents of children by age group. And you can see that the children are divided into those with moderate haemophilia A, which are the blue dots, and severe haemophilia with the green dots. And you can see that even in the oldest children, the 12 to 17-year-olds, parents were reporting that they were spending several hours per week looking after their teenage children. And that is around helping them to self-infuse, helping them to manage their condition, and bringing them to hospital. So just because they're older doesn't mean the burden gets less. And if we think then about the other things, it's not just around the actual burden for the parent, it's about what does the parent then do for the other children. So we know that there's a lack of parental attention if the whole focus is on haemophilia and not on other areas of your child's well-being. There's a perception that this is going to be less of an issue in haemophilia, but not in other bleeding disorders now with the new therapies. So the perception is that if you're on Immiscismab once a week, that the treatment burden will be less, but we don't know that. Nobody's actually looked at it. We talk about personalised treatment, and that's great if you're an adult and you're having your prophylaxis every 36 hours, because that's what your individual PK says. But how do you personalise the treatment for 5 children with severe bleeding disorders in one family? And does that personalisation, although it's the right thing for the child, increase the burden for the family? We also expect parents to record everything that they're doing. So although Charlie Hay here has said that the data is a valuable tool that may improve treatment compliance and optimise treatment regimens for people, actually expecting parents to record everything that they're doing for their children is also a huge burden. And as Natalie's just said, we need to know more about pain. We know that children with bleeding disorders suffer pain, but we're not very good at asking about it, yet alone even treating it. We know that that impacts on their quality of life, that causes anxiety and more burden. The other people that we don't think about are the rest of the family. So who is looking at siblings and the impact of having a brother or a sister with a bleeding disorder? What does it mean for the siblings who maybe lack parental attention? They maybe have negative social emotions. So their brother goes off to hospital with their mum. He comes back, he's had a nice day out. They think in the city where the hospital is, he might come back with a toy or some sweets, and the children that have been left behind have been sent to school and had a generally horrible day. So they perceive that their brother or sister is having a better time than they are. They don't come to the hospital, they don't know what we're doing. We need to also think about some of the siblings are carriers of the condition themselves. They may be the mothers of our future, and that perception of what is happening to their small brother will impact on their ability to cope as a parent in the future. It's not just children, this is also happening in adults. So here's 2 studies, one in the US and one again in Europe, so Chess is European. And you can see that adults express haemophilia related distress if you talk to them and you ask them about it. So they talk about feeling isolated. They have concerns about physical functioning, which goes back to their pain, but also back to the obesity and overweight that we've discussed earlier. They have concerns about the future, so for insurance and aging and disability, and where will they live and who will look after them if they need to go into some kind of care facility. And that leads to that additional scary feeling of the burden and fear of acute bleed. So what would happen if they had an acute bleed and they couldn't treat themselves? And the CHEST-2 data, which is the European data, has shown that the quality of life is impaired in young adults, even those that have
Kate?
Sorry, my computer threw me out, so let's hopefully we'll carry on.
You're back. This is great, thank you.
I now can't move the slides there. Could somebody move the slide for me? Next slide, please. Okay, so thinking then about women, we've talked about women being carriers. Next bit, please. We need to think about the psychology. I've already talked a little bit about the guilt and blame that women perhaps feel. And we need to think about the impact of women being affected with bleeding disorders themselves. So are they just carriers of a condition, or are they women with the bleeding disorder themselves? Oh. We need to think also about past history with viruses. So we were talking earlier about hepatitis C, but even if your granddad had HIV or hepatitis C, that is still impacting on you potentially. So for ladies who have babies with haemophilia, they maybe have concerns around infusing their child. When we're talking about gene therapy, suddenly we're saying a virus or a vector is a good thing. And actually some people are still concerned that the virus from the past is an issue. And we have survivor guilt and post-traumatic stress disorder. So surviving siblings or family members or peers of those who were contaminated with bloodborne viruses in the past. and particularly in the UK at the moment, where we're having the ongoing inquiry into contaminated blood, the impact of that is causing a concern for people with bleeding disorders. So as we move on to gene therapy, whilst we all think it's going to be a great outcome and that might cause less anxiety and depression for people with haemophilia who've gone through gene therapy, and they may, as some have reported, very positive feelings and having a new outlook on life. But for some, they might need emotional support to deal with the feelings of loss of identity or no longer belonging to the haemophilia community, and uncertainty around the expression and the longitude of expression of factor levels, and the loss of past opportunities. So suddenly they can do things that they couldn't do before. And if we don't ask the right questions, we will never know if we're getting the right answers. And the way to do that is by using outcome assessments. And I'm a fan of some of these, but not all of them. Sometimes I think we just need to talk to people more than giving them yet another questionnaire. But in the chapter 11 of the latest WFH guidelines talks about the outcome assessments that we can do that are relevant to people with all kinds of bleeding disorders, not just those with haemophilia. And if we look at the ones that are related to mental health, you can see here we have in section 11.5 things around environmental and personal factors. So environmental is access to treatment or insurance, and personal might be resilience and treatment adherence. There are economic factors in section 11.6, which are around access to medicines, care and services, but also indirect ones that like out-of-pocket expenses, burden and loss of work. There are quality of life assessment tools that we can use, and those could be generic, such as the EQ5D, and haemophilia specific ones. And then there are patient-reported outcomes, which are the most important. Again, EQ5D, but also pain, activity and burden. And if you look at mental health across all of those areas, it fits in very nicely with quality of life, with personal factors of resilience, with economic factors, and with what patients are telling us in their outcome reports. So in section 11.9, it tells us there's a core set of measures to use in clinic or for research. And I think we need to use different things differently. And as Cedric was saying earlier, if we're going to take patients' heights and weights, we need to tell them what their BMI is. If we're going to expect them to fill in lots of quality of life assessment tools, we should tell them what their results for those are as well. We need to think about the value of care that is created for patients. As healthcare professionals, we usually select the instruments that we think are relevant for patients and their families, but actually we need to engage them in that. So I'm delighted to see that the PROBE study now has a report back to patients to give them their own individualised data. Wherever possible, we should be doing something that is standardised so we can compare treatments and centres and patient cohorts. Trying to measure a minimum set for every major condition that the patient might have, not just for those with severe haemophilia. So where is the quality of life assessment tool for people with rare bleeding disorders, for example? And the WFH World Bleeding Disorders Registry is collecting that uniform standardised patient data and outcomes. And once the gene therapy registry comes online, it will do the same. And all of that means that we can advance clinical care and studies for patients and improve their outcomes. So to conclude, mental health is as important as physical health. And within our multidisciplinary haemophilia teams, hopefully we have access to people who can focus on the mental health for the patient, but also for the family. So it's not just the patient, it's his mum, his dad, his granny, his siblings, whoever. To think about treatment and how that impacts on physical and mental health, but also to recognise that if you don't have access to treatment, that will also have a huge impact. We need much better focus on mental health outcomes that are relevant to people with bleeding disorders, that give us the ability to provide better support and care, particularly with all of those new treatments on the horizon. And I think because of those new treatments, the importance of talking about haemophilia and other bleeding disorders, mental health is gaining visibility. And I will stop there. Thank you very much.
Thank you. Thank you, Kia, for a great talk about a very important topic. So a few questions. There is one question about how to promote physical activity to someone with hemophilia who doesn't have access to prophylaxis. So yes, I emphasize the importance of physical activity. Well, yes, I can understand that without prophylaxis that can be complicated, but still convinced that you can still engage in physical activity, even if there is no full prophylactic regimen in place. But again, having, you know, someone, a local physio, providing, you know, some guidance might still be useful. So it's not because you are not on prophylaxis that you cannot be physically active. I think you need some counseling, and you can still engage in physical activity without major risk of bleed. There was a comment about, maybe this is for you, Nathalie. Susan wanted to re-emphasize the fact that there is a pain treatment planning questionnaire that has been developed for the bleeding disorder community. And she also shared with us the websites. Nathalie, do you use that questionnaire? Are you aware of it?
I saw the publication recently. I think it's great news that that such a questionnaire is developing, and I'm very happy, or I will be very happy when I see the results of it, because as every questionnaire, it needs to be validated and examined for its clinometric properties. But it's very good news that at least something exists, and if it's a valid questionnaire, we will use it in future research, certainly.
And Nathalie, you are now really involved in hemophilia care, and you meet many colleagues around the globe frequently. So do you think that we pay more and more attention to pain nowadays compared to what we were doing 3-5 years ago?
Yes, I think both from the healthcare professionals as from the patient side, there is I would say an awareness to speak about it, and I think it's great news for the hemophilia treatment centers and for the hemophilic community, not only in patients with hemophilia but also in von Willebrand and in carriers. The pain problematic is now discussed. And I hope that we will be able to do research on a more larger scale to give some tools to help patients and healthcare providers in the clinics.
Okay, thank you. Bruce, I can see that you are still with us. Maybe there is one issue that we did not emphasize enough. This is the major issue of liver steatosis, which is also a major complications of the metabolic syndrome and obesity. So can you comment on this? That could be the next challenge for the future and for our patient.
Yeah, I wish I had a great answer, Cedric. You and I agree that while hepatitis C, I think for many of us is going away, we do not have a treatment for NASH yet. It's a topic of very important research. I would again suggest that families and patients could look on the same scale that I use to see now patients with bleeding disorders can have fibrosis and cirrhosis from the fatty liver disease. So the same things I talked about. There was a question before, do we have an anti-fibrotic or an anti-cirrhotic medication? I would be glad to say yes, and I could go to Stockholm and get my Nobel Prize if I had one, but we do not yet have that. But the screening for patients that are obese, that have, as you mentioned, all those other complicating metabolic factors would be the same as I went through for the hepatitis C people.
Thank you, Bruce. Maybe, Kate, I don't have specific question for you from the audience, but is there a specific, message that you would share? We are really close to the end of this webinar.
So yeah, my message is we can only do what we do well if we talk to patients to find out what it is that they worry about, what they need, and how we can support them to get that. So we have to use more than questionnaires.
I agree. And I think we need to have long discussions with our patients and have a really holistic view, not only of the medical aspect, but also explore their mental ecosystem. And I think this is really key if we want to address issues like liver steatosis, obesity, pain in the future. So we are really close to the end. It's nearly 4 o'clock Brussels time. So, well, I would like to echo, what Jean-Emmanuel just wrote on the chat that that was a very important and excellent webinar, and I fully agree. I think these were 6 highly complementary topics addressing very important issues in our daily practice and daily life as a patients or patients community. So I would like to thank all of you for your great talk, major involvement, great slides, and also the staff, all the people behind the scene who made this possible again. So we had many participants, major enthusiasm for this kind of activity, and that can only stimulate us to repeat this kind of initiative in 2022. So on behalf of my colleagues here, I would like to thank all of you. I wish you a great holiday season, and hope to see you again very early in 2022. Bye-bye to all of you.